perfectly sure to talk a little bit about Vivek Sivaraman before we announce the winners of the prize that we give in his memory.
I probably don't need a microphone, I think I'm quite loud. Can everyone hear me at the back? Yeah. So they always say it's only the good that die young. Quite a few of the people in this room will have known Vivek very well, and some of you will only have ever heard of his name. We are constantly amazed, delighted, surprised and inspired by our excellent trainees who give us probably far more than we give them during the course of their training. Unfortunately for all of you lot, Vivek still remains the #1 trainee in my memory. He died extremely young and very suddenly, leaving behind a very young family and a load of absolutely devastated friends and colleagues. And he was the brightest and the best, I think, because he was very good clinically. He had a very good research career ahead of him, but he was also a really nice guy, which actually makes it all a bit unattainable for the rest of us to follow him. But in his memory, he died in 2015, and in his memory, the idea was that we should have a prize to recognise and acknowledge the hard work that the trainees following on from him would achieve. So it's in his honour that this was set up. And hopefully it will continue to carry on, and hopefully you will all get inspired to do all the good work that we completely rely on to make us look good. So thank you very much. So the work that was submitted has been weighed and measured, and a decision has been made by the great professor beside me. So I'll leave her to do that, and maybe Aidan, you want to come and do the handshaking, seeing as you're the TPD.
I'm not sure they'll necessarily be here.
I'm not sure they'll be here either, but let's find out.
Okay.
So,
if you want to, you can all line up at the end and get your hand shaken.
So in reverse order, so in third place, we have Innovation with Jelly, Central Venous Catheter Insertion Simulation Skills course, presented by Alexandra Ballantyne.
Who is here? Yes.
Who is here? Congratulations. In second place, we have Trainee-Led Regional Teaching, a pilot programme and trainee survey data, led by Samuel Williams with Charles Henshaw. Sam Williams? No, but congratulations to him again. And in first place, we have, drumroll please, Perioperative redox and bioenergetic changes after major surgery and their association with post-operative outcomes. So if any of you understood that, that's a good start. Presented by Charlie Stevens and team. Alex, thank you for being here. In traditional fashion, you will get a prize, but not today. So consider this congratulations and a firm handshake from us, and thank you. And something will be winging its way to you in the future, so well done. Thank you, and to everyone that's supported. So we're going to move on now to the main order of the day, which is the William Squire Memorial Lecture. And some of the earlier career colleagues in the room may not know the background to who William Squire is and why we have named a lecture in his honour. But William Squire administered the first anaesthetic in England on the 19th of December 1846. That blue plaque, I'm sure most of you will know, is on the house on Gower Street. So if you carry on walking down the road past GCL on the left-hand side, you'll see this blue plaque where University College Hospital used to be. It's still a building that's owned by University College London. And William Squire is this fella here in the background. He was a medical student. The surgeon was a guy called Robert Liston, who, like all surgeons in those days, was a vascular surgeon who just chopped off people's gangrenous legs, basically. But they had heard about what they'd done in America a few months earlier, and Liston was keen to try it. So his mate, who was another doctor, had a nephew who was a medical student called William Squire, and he got William Squire to come along and do the needful. And the apparatus that he used, which is known as the Squire apparatus, I think that sits in the Association of Anaesthetists archive in their museum for people to see. So it's a very proud fact about UCLH, UCH as it was, and UCL, that we can say that it was here that the first anaesthetic in England was given. So our lecturer this evening is Professor Denny Levett. And Denny is a friend to many of us because she trained in this school of anaesthesia with many of us. She was a trainee with us. She won the gold medal for the final FRCA. She then, shortly after that, went with a bunch of others, reprobates that many of you know, off to Nepal on the extreme Everest expedition, which took notably some people to the summit of Mount Everest, but many, many more people to Everest Base Camp to study their physiology at altitude, to try and understand the dynamics of oxygen dynamics, and thinking about how that hypoxia that you get at altitude might mimic the hypoxia that you get in critical illness, and what we can learn from that. And subsequent to that, and Denny was the research lead for that project. Subsequent to that, Denny has made an international name for herself as an expert in perioperative medicine, and very specifically, as well as more generally, in prehabilitation and exercise as an important form of therapy for patients undergoing major surgery. She is the lead for the perioperative service in Southampton, the clinical service. She's a professor of perioperative medicine and a consultant anaesthetist and intensivist in Southampton. She was the founding chair of the Perioperative Exercise Training and Testing Society, or POETS, and she's now the co-chair of the International Society, the name of which I can't fully remember, but the equivalent society internationally for exercise training and testing in perioperative medicine. I'm also very proud to say she's my good friend. She's also, to some of us, known as the wife of Professor Mike Greycott, and I only say that because if her own achievements weren't enough, to be a partner of someone who's achieved a lot, I think is amazing. And she's brought up 3 completely remarkable kids, and I can say that from first-hand knowledge. So it's a real pleasure to introduce Denny, our old friend, to give this William Squire Memorial Lecture on exercise is perioperative medicine. Thank you, Denny.
Thank you, Ramani, and good evening, everybody. I was thinking earlier today, it's the first time I've done a live lecture since before COVID, because we haven't had any, which was demonstrated by the fact that I forgot my adapter, I forgot my pointer. This is actually a pussycat toy to entertain them that I got from the pet shop on the way here from the station. So there you go. But fortunately, I did manage to go to PC World. I remembered that was near here from my day's training. So, good evening. As Ramani alluded to, I'm a perioperative physician, and actually I lead the critical care elective surgical post-op HDU in Southampton. And actually I spend quite a lot of my time still doing clinical work. I spend about 60% clinical time and about 40% research. So my academic interest in exercise really first arose as part of the Caldwell Extreme Everest expedition. And as you can see here, we were a slightly eccentric lot that took exercise bikes and full cardiopulmonary exercise testing equipment, and actually I've got an arterial line in there, so that we could investigate and evaluate the effect of environmental hypoxia on exercise capacity particularly, and also importantly on mitochondrial function, in terms of mitochondrial oxygen use and efficiency. So that's where my sort of physiological interest in exercise started, and that was part of my PhD. But when I came back to England, I became increasingly interested in how exercise capacity and physical fitness are important for health outcomes. And also interested and slightly more alarmed with this sort of data, because the more you look at the epidemiological data about physical inactivity and exercise, what you discover is that there are alarming rates of physical inactivity that are increasing every time that they're measured. So much so that in 2012, the World Health Organization declared that there was a global inactivity pandemic. And this was based on the fact that in the preceding 5 years, during which there had in theory been a campaign to increase global activity by 10%, what had actually happened was that global levels of inactivity had gone from 23% to 28%, which is not reassuring. The burden of inactivity falls particularly on women. So that previous data was men, and you can see there's more dark colours, so it's worse amongst women. And also particularly on high-income countries, so the developed world rather than the developing world, although it is increasing in low-income countries as well as in high-income countries. And currently, it's estimated that about 4.5 million people annually die as a direct result of physical inactivity, and about 1 in 10 premature deaths can be laid at the door of being unfit and lack of physical activity. And I think it's something we don't perhaps think about enough. I know I'm always going on about exercise, but not everybody else is. And what about the UK? How are we faring in this global inactivity problem? Well, you'll be pleased to see, as you can see here on the left, we have the leading levels of inactivity in Europe, 42% for women and 32% for men. And again, I'm sorry to say that every time this is looked at, it gets worse. And I mean, does it really matter? We might all be sitting on couches, drinking. Does it have an effect on health outcomes? Well, it really does, and a really profound effect, much more profound than anything else that I think that we do on a day-to-day basis. So there's this concept of the population attributable fraction. So it's a really useful way to compare the impact of, in this case, physical inactivity from one disease with another disease. And what it is that the percentage of cases of that disease, in this case colorectal cancer, in the UK that can be directly attributed to lack of physical activity, because physical inactivity has a causal role in colorectal cancer. And this is something else that I think is remarkably little is known about this, even amongst the medical profession, because I can see some people shaking their heads now and looking a bit surprised by this fact. So being unfit is an etiological factor in the development of 6 cancers that we know about currently, and the evidence is increasing in other cancers. In fact, pretty much in all cancer, apart from malignant melanoma, maybe for obvious reasons, it appears that you're more likely to get cancer if you are physically inactive. And it's reached the threshold of being causal in colorectal cancer, breast cancer, lung cancer, endometrial cancer, and esophageal cancer. So it's a really important fact, and I can tell you most patients aren't aware of this either. And not only does it have an etiological role in the development of cancer, but if you are unfit when you get a diagnosis of cancer, your outcomes from cancer are worse, and that's modifiable. So that if you change your exercise behaviour after your diagnosis, you improve your outcome. So it's a hugely important risk factor for health outcomes because it's modifiable and you can actually do something about it. Equally, unfortunately, if you were fit at medical school, it doesn't last the next 40 years. I'm afraid you develop the risk of what you're doing at that point in time. So the good news is it's not genetically determined. I'm afraid you can't say you're genetically determined to be a couch potato. It is reversible. As you change your exercise behaviour, its impact on these chronic diseases will change, which is why it's so important, and it's why it's important that we communicate that to patients. So all-cause mortality, you can see here, type 2 diabetes, coronary artery disease. Those are just some of the major impacts. Another major impact is on mental health, which I think, again, people underestimate. Exercise activity and exercise programs are an effective treatment for mild unipolar depression. In fact, it would take more than, I think the latest meta-analysis said it would take more than 100 negative trials before you could get rid of that result that suggests it's as effective as SSRIs in the treatment of unipolar depression. So if you're not even worried about the health outcomes, you might be worried about that headline cost because it's really expensive. And that's because people are off work because of illness and its indirect effects on mental health as well. And this was before the pandemic. And we all know that most patients have been sitting at home for 2 years, or many of us have been gaining weight and doing very little. So the situation is likely to have got acutely worse, and there is increasing publication of data suggesting that it is. So now there's a bit of emotional blackmail. If you're not going to do it for yourself or your patients, what about your children? Okay? So that headline figure at the bottom is totally shocking. 40% of 5 to 15-year-olds are physically inactive. And by the way, what's the definition of physically inactive? This is all based on World Health Organization guidance for what you should be doing. And for children, that's 60 minutes of physical activity daily. And again, every time that's measured, it's getting worse as screen time increases. And more than 80% of the world's population are insufficiently active. So inactivity is an issue. Patients, and I would say a lot of physicians, are not entirely aware of all the impacts of that. It's a modifiable factor, and I think it's something we should think about a little bit more in our daily practice. The final thing to say, for those of you who want your children to go to Oxford and Cambridge, is that if they do more exercise, they do better academically. And it's really interesting. So there's been interventional studies in the States, Northern Canada, with inactive children. They do standardized testing. They do an interventional 2-month exercise program, and the children in the exercise group improve their standardized testing scores. So if you want them to get into Cambridge, you need to get them to go and do some exercise. Excellent. Right.
Or UCL.
Or UCL. No. Okay, it's only the third best university. Right. So, moving on to something a bit more relevant to perhaps everybody's day job in the room. This is a sort of the structure in my mind, how I think about perioperative medicine and the perioperative care pathway. And what I hope I'm going to do in the next 20 minutes or so is to convince you, as I'm convinced, that one of the more important things to think about all the way through that pathway is exercise interventions, physical activity, functional capacity, because it has an impact, the evaluation of it or improving it on many of the, in fact, all of the elements in this pathway. So if you were to take a patient, so we are always saying that perioperative medicine is about patient-centered care. So patient-centered care, in the first instance, you would hope that the partner's involved, a patient is a partner in their own care and they're involved in the decision-making. So in order for them to make an informed decision, you need an individualized, accurate estimate of risk. And in order to do that, you need some tools. And I think we would all say that we don't have the perfect tool, perhaps, at the moment. But one of the tools that's useful is to look at functional capacity, certainly as a contributory factor, along with comorbidities and surgical type for assessing risk. Having made the decision in a shared decision-making consultation with the patients that surgery is the right way to go, then I think if you think about your relative, what you would next expect is that they're well prepared for that operation. And I like to think of that as two parallel, contemporaneous, and equally important interventions that need to happen between that decision to operate and turning up on the operating table, which I don't think we've been doing really effectively always, certainly to date. I think we all think we optimise everybody, but the reality is there's a lot of last-minute pre-assessment, certainly in my neck of the woods, and it's quite difficult to get hold of patients to do this. But if it were you or a relative of yours, I suspect you would like that to happen. And so optimising healthcare behaviour, so that's exercise capacity, making sure that their nutritional state is appropriate for surgery, and also any psychological barriers to either changing their behaviour or to engaging with healthcare are also really important to address. So then, having finally got to the time of surgery, you'd hope that they're well cared for during that operation. And that means choosing the right perioperative care environment, be that an HDU or an enhanced care unit or the ward. And again, that is determined to some extent by your risk assessment and what's happened in between times as to whether you've modified that with any of your interventions here. And then on the first day after surgery, you want the patient to get out of bed. I've seen I'm not sure if it's been published yet, but Ramani's data from PQIP looking at eating, drinking and mobilising as a really important predictor of post-operative morbidity. So you need to have told the patient before they arrive, when they're not in pain, half asleep and a bit doped out on some morphine, that they need to know that number one objective on day one is getting out of bed and moving. And then they're more likely to go home sooner and they're more likely to recover more quickly. And then finally, once they've been discharged from hospital, I do think we abandon people somewhat. The reason patients have operations in the first place is either to prevent mortality because they've got a life-threatening condition such as cancer, in which case they would hope to get back to at least their current quality of life, or it's because they're doing something to improve their quality of life, i.e. they've got joint pain and they'd like to have a joint replacement. So we are hoping at the end of surgery that we would get the patient back to their previous function, and that involves some rehabilitation, which we'll come back to again, which involves exercise. So one of the first issues is, what do we actually mean by fitness for surgery, functional capacity? I think lots of people bandy that term around a lot, and when you really specifically ask what that means, people sort of shuffle a bit, and it depends, fit sort of type thing. So you can define it in various ways. If you want to be physiological about it, and if you go to the American College of Cardiology, they will give a physiological definition which is about maximum aerobic exercise capacity. Because in order to do anything, you need a certain amount of exercise capacity, and they define it as your VO2 peak, as in what we measure with the cardiopulmonary exercise test. So your maximum functional capacity, or your functional capacity, is your ability to do aerobic work. If you spoke to an occupational therapist, on the other hand, they would give you a much more functional definition, but actually it comes back down to the same thing. What are they saying is, what can you do? And you need to consume oxygen to do anything, so the two are clearly equally related. This, if you look at it and measure it like this, is a bit easier to be objective, but this is really important to what the patient can actually do with their life. And for them, that's probably more important. They're not really particularly interested in their peak VO2. And why is functional capacity so useful as a combined variable? It's really because it reflects lots of things that are important about the patient. So first of all, their health behaviours. Have they been eating unhealthily? Are they overweight? Are they morbidly obese? Are they malnourished? Have they lost weight if they've got cancer? Clearly their exercise behaviour as well. But their comorbidities. The functional impact of your comorbidity is massively important. You know that if you see a COPD on the pre-assessment chart, but then it says beneath that the patient cycles 4 times a week, you're not bothered by the COPD, are you? I mean, is there anything we can do to optimise COPD apart from change the inhaler? Sorry if there's a respiratory physician in the room, but there's not very many optimisable factors. In fact, one of the best treatments to reduce hospital admissions with COPD is exercise and pulmonary rehab. So what if they've got heart failure? We come back to the same situation. If they've decompensated their breathless on exertion, then you want to know about them. If they're completely fine and they had that diagnosis 10 years ago and they've been on 1 tablet of furosemide, do you care? Not really. And again, what's the best treatment for heart failure? Or one of them? Exercise. Again, underrepresented in the treatment, but it's important. And the same goes for your diabetes. So it's important because it tells you about what's the functional impact of those comorbidities. And from my perspective, it tells me, am I really bothered about them or not? If they're rushing about running marathons, I really don't mind what's on the comorbidity list. And then finally, I think we underestimate the importance of psychological factors. And by this, I don't actually usually mean psychiatric disease. There is an entire behavioural science around how you get people to change their behaviour and do what you want them to do. And waggling your finger at them doesn't tend to work, surprisingly. If they've known it's bad for them for years, they're not going to suddenly take to exercise just because you've waved your finger at them. So self-efficacy is this construct which basically describes your ability to believe that you can manage your own life. So interestingly, it's situationally dependent. So people may have self-efficacy for healthcare and not be so good at organisation. But on the whole, it tends to be continuous across domains. And people with low self-efficacy are the patients that don't turn up to outpatients, forget to take their medication, make everything your problem and none of it's their problem. There's one that came to surgery school a couple of weeks ago when I suggested exercise, said, "Don't you understand, I'm sick?" So it's that sort of illness behaviour sort of person as opposed to taking control of it. And that can massively impact their engagement with prehabilitation, their engagement with early mobilisation, and actually their engagement with rehab and getting back to a decent quality of life. So it's important. Another really important thing about functional capacity is to understand the difference between physical activity and exercise, and I think this is going to become increasingly important because by the end of today I'm going to convince you there's enough evidence that we should all be implementing a prehab programme now. But there's a lot of misunderstanding about this. So everybody thinks exercise is good for you, and if you do 10,000 steps you'll be fine. So physical activity is good for you, I'm not saying it's not, but it is not the same as exercise. It's not biologically the same as exercise. It doesn't induce the same anti-inflammatory effects. It doesn't have the same effect on mitochondrial function. So I think we need to be very careful when we look at what exercise programs have been demonstrated in trials to be effective at changing fitness and effective at changing outcomes, They tend to be individualised, personalised, aerobic, and most of the time high intensity. That probably doesn't matter. That's just a time duration effect, exercise programs. And we don't know yet, because we don't understand the mechanism, if exercise is working via improving your fitness or if it's actually doing something much more important on an inflammatory cascade, et cetera, in cancer, particularly the etiology of it, for example. So please don't believe that giving a patient, giving him a MyZone and telling him to do 10,000 steps is going to do the same as one of the high-intensity interval training programs. Because the other issue with physical activity is it's not really aimed at improving fitness, and it's fitness that's been shown to be related to outcome. Fitness and physical activity and frailty clearly overlap. Now, I think this is really important because these are constructs a lot of people want to put into risk models at the moment. Rightly so, because frail patients do badly. I sometimes am a slight believer that frailty is a bit emperor's new clothes, in that if you look at the clinical frailty scale on number 9, it tells you the patient's going to be dead in 6 weeks, and the fact that they do badly after their operation doesn't seem terribly surprising to me. And the number 1 on the scale says they're rushing about doing what we said at the beginning, so it seems to be a lot of overlap with what we were talking about. And I'm not saying it's not important, but be aware that these are terribly confounded. The definition of frailty, so you can either go for the frailty phenotype up here, which is it's a functional definition about being unfit, essentially, reduced grip strength, slow walking speed, low level of activity. Or there's the index, which is about how many comorbidities you have, but very importantly, you have to have functional deficits with those comorbidities to be frail, otherwise you're just multiply comorbid. So you can have a lot of chronic health conditions but not be frail, and vice versa. So a list of comorbidities does not equal frailty, but there is massive overlap with physical fitness and activity. And then the other element is muscle function, sarcopenia, muscle mass. So sarcopenia, which again, we're interested in looking at the relationship with outcome, partly because it's reasonably easy to measure, is about muscle mass, but not just muscle mass. The new, more recent definitions of sarcopenia that are now established all require there to be a reduced function of the muscle as well. So again, reduced grip strength, slow walking speed, slow sit to stand. So those are very confounded variables. When we start to look at multivariable, more complex modelling of perioperative risk, we really need to tease out, if we put another one of these tools in, is it actually helping? So Ramani did a very nice study looking, I saw it at the frailty scale, I remember because it went with my bias, on top of the POSSUM score. They were both related to outcome, but if you did a frailty score as well as the POSSUM score, it didn't tell you anything additional, because actually there's a lot of the same information in both. So just be aware of that. And we've done some studies in Southampton looking at the relationship between sarcopenia, which is about muscle mass, myostenosis, which tells you about muscle quality. It's about how much fat's in the muscle. So poor quality muscle is associated with very poor outcome. And from these are both hepatobiliary and upper GI cancer patients, was more predictive of poor outcome than muscle mass was. And interestingly, we looked at the relationship between that and fitness. So here you've basically got on the x-axis a measure of smooth muscle radiation attenuation, so it's quality of muscle, and here you've got VO2 peak. So you can see, not surprisingly, the more muscle you have, the fitter you tend to be. But interestingly, when we looked at clinical outcomes in these patients, the functional capacity was more predictive than the degree of sarcopenia or the degree of myostenosis, and that held in both upper GI surgery and HPB surgery, and it's going to hold in colorectal surgery too, which we will be publishing shortly. So, fitness and perioperative risk. I've said lots of things that fitness is important for health outcomes. I've said it might be important in perioperative risk. How do we measure it? That's the next important thing. Well, one of the things about fitness is it's quite difficult to just subjectively get right. We think we're quite good at it, but I'm not sure we always are when we're talking about functional capacity. So, if I were to say to you, one of these guys has cancer, could you tell from the end of the bedogram about that? Not necessarily. And in fact, some of us might say, well, I don't know, he doesn't look particularly cachectic. He does look a bit cachectic, maybe it's him. But actually that chap is somebody called Ed Whitlock, for those of you who are into running. He is the world record holder marathon runner. He's at 86, a year and a half ago, I think it was. He ran some marathon somewhere, the Montreal Marathon, in 2 hours and 56 minutes. Shocking. I still can't get over that. I've never managed that. Yeah, so there you go. So his sarcopenia is because he's a long-distance runner, even though he's 86. It's quite difficult to see on the outside. So are there more objective ways? And what we've got is basically subjective clinical assessment at the end of the bedogram. We've got subjective questionnaires. Now, it still is asking a patient what they think, but at least you've got standardized questions, so it's easier to compare across patients. And then finally, you've got some objective tests. The gold standard is this kit here, the cardiopulmonary exercise test, but there are other easier tests like the shuttle walk test, the time to get up and go, the 6-minute walk test, which I'm not a great fan of for various reasons. But you can use all of those in different ways. And there's become a great love of cardiopulmonary exercise testing in the UK, and it's been implemented and adopted, and I'm a fan of that as well. Based initially on Paul Older's data, who came and was a visiting prof at UCL for several months and taught us all initially. And based on this sort of data, which sort of suggested that patients who were fitter, as measured by cardiopulmonary exercise testing, VO2 peak or anaerobic threshold, or patients who had evidence of better VQ matching, which is what the VE-VCO2 variable tells you, do better after surgery in terms of morbidity and mortality. And there were lots of single-centre small studies saying this, and then we got to doing some multi-centre studies looking at different surgical types. So this is colorectal cancer surgery from 6 centres across the UK that we did through POETS, and slightly, reassuringly looking quite precise, reasonable precision anyway, area under the curve for morbidity. But the problem is they were mostly retrospective and they were confounded, and so back in the mid-tweens, a group went on to propose the MET study, which was to try and look at which way of measuring functional capacity may be better at predicting post-operative outcomes. So I think this is quite a difficult study. I'm not sure it's really clarified anything very much, by mistake, as often happens. So this was meant to be a high-risk surgical group. So the first thing to say is since mortality was 0.4%, it wasn't a high-risk surgical group. So we didn't achieve that aim. As a consequence, the primary outcome, this was an American-funded study, which was a cardiac outcome, which if I were to ask you of the middle column, which do you think is the most important outcome? So who thinks death or myocardial infarction is the most clinically important outcome there? Who thinks death or myocardial injury, that's one of my favourites, myocardial injury, troponinitis, or who thinks moderate to severe complications, which includes death? Yeah, so it's really interesting, because if you ask that question in America, they all say something different, and I do think that partly describes things. Our bias was we wanted to have the moderate to severe complications as the primary outcome. And one of the problems about composite outcomes, if you have something like this, because there were so few deaths, and there weren't very many MIs, but there were a few more than there were deaths, that outcome really becomes more about MI. And half of those MIs, as it turned out, were only diagnosed on the basis of ECG and troponin, and they had no clinical impact on the patient, and they went home with a normal length of stay, which makes me feel, that's in the paper appendices, which makes me think even less that they're important. So what I'd really most say is that everything was pretty disappointing in this study. The first thing is that our clinical acumen is terrible. That was the most consistent thing. We weren't good at predicting anything. So that's when clinicians were just asked how fit they thought they were. This isn't quite the same as saying what do you think their risk is, because I think there's other studies that say different about clinical acumen. But when we asked them what do you think their functional capacity is in this study, they estimated it very poorly. And it wasn't related to a single clinical outcome or to any of the other measures of functional capacity. So I think take-home message number one, we're not very good at it, so do something more objective than just thinking about it. DARSA appeared to predict, I can't really make sense, it doesn't actually make sense. It predicted post-operative cardiac complications, and the DARSA is a physical activity score that essentially asks what you can do from getting dressed to having sexual activity, which always causes much excitement, because patients ask, can I or do I? And then there's a great debate about whether they could if they really wanted to, because they haven't tried recently. I had a conversation with that. So, so why that would predict whether you have an MI, but not whether you have another complication, I don't know. And the only thing that predict in-hospital moderate to severe complications was cardiopulmonary exercise testing. And then they did 2 forms of modelling, first looking at the odds ratio, but then they did something called the net reclassification index, which is basically to take into account age, sex, cardiac risk factors, and surgery type. And then the DARSA positive result disappears. And I think the real take-home message is if the analysis changes the result, you should be slightly concerned about the validity or the strength of weight you should put on the result. Really helpfully, because one of the problems was that was the only prospective data set. It's just been published, and we're in the middle of doing a slightly bigger analysis of the CPET data from the PQIP data set. So we've got enough now. So there's nearly 3,000 prospectively collected CPET tests and perioperative outcomes. And the early data from that suggests that CPET variables were predictive of major complications, post-operative 30-day mortality, and looking at peak power, which is just really another way of looking at peak exercise capacity, also predicted both complications and mortality. The area under the ROC curves for mortality around about 0.7, so actually respectable. The complications between 0.6 and 0.7, so not as precise, but certainly looks like that within how it's used in the UK, some clinical utility. And I think that's another thing to say about the MET study. A number of the centres in that study took up CPET for that study, and there is certainly a learning curve in it, which may have impacted results as well. So one of the questions going forward, though, that I do think is interesting from that study is DARSA useful? Because it would be really useful not to have to CPET everybody and to rule some people out or rule some people in. And so we've been collecting DARSA for the last couple of years in Southampton. So this is we have a sort of prospective inception cohort, and we've done an excise test on, we've always done a DARSA, and we were waiting until we had sufficient numbers of people. This isn't published at the moment, but it's just over, I think it was 3,500 patients. And what we did was look at the relationship between your DARSA score and your measured VO2 peak. So you can see there is a relationship, but you can also see the problem. There's a lot of noise around that relationship. And we looked at the calibration of the equation, because the first DARSA was first used in heart failure patients, not surgical patients. And it's quite clear from both the MET study and from our data is that it overestimates the equation, and that overestimates VO2 peak. So we recalibrated that. And interestingly, I did think this was quite interesting. When you look at anybody that's looked at DARSA and tried to rule out or rule in, there seems to be a threshold around about 34. It comes out recurrently in studies. And interestingly, when you look at the calibration for VO2 peak, when we recalibrated, 34 is associated with a VO2 peak of around about 15, which again, across multiple surgical types, is usually where you start to get a kick up in risk threshold. So that's interesting. And interestingly, in our population, it was associated with post-operative morbidity, 30, 90, and 1-year mortality. So I think, I do think it's probably going to be a useful tool to do that. That's not fully published yet. The research fellow's gone on maternity leave, so we'll be later in the year that hopefully we'll finally finish that analysis, because I think it's a really useful tool to know, to get an estimate that is at least helpful. I think another thing to say really about risk assessment is that I don't think we've got the ideal models yet, and this is something again that we're collaborating. You may not know that you're collaborating with Southampton, and Ramani is collaborating with us, and as you can see, Adelaide and Plymouth and York, to try and use routinely collected hospital data along with CPET data, along with wearable technology, to get some large data sets together to try and get some machine learning algorithms so that we could actually know about risk in a more contemporaneous fashion, and that as we intervene on a patient, like they have prehab or they go to theatre, we thought they were high risk, they were completely cardiovascularly stable the whole way through. I'm sure that patient post-operatively didn't bleed much, their lactate's 1 in recovery, probably has a different profile from the patient the minute you induce them, crashed their blood pressure, was unhappy all the way through, is oliguric at the end and cold and acidotic, and it would be useful to know that in a contemporaneous fashion. So that's something we're working on now. Hopefully in the future we'll have something more interesting to say. So I've told you that exercise is really important. Is there actually any evidence that excising people in the small window you have before surgery, it's a large window in our trust if it's orthopaedic surgery, but if it's cancer surgery, it's usually only a small window. So on the basis of that data, the team, the Fit for Surgery group, and hands up, this is myself, Mike, Sandy Jack, Malcolm West, so we've all worked on all of these studies together. Back so I guess it was perhaps 2010-12, after we had all the data about fitness predicting outcome, we decided that we'd like to start training patients. We'd like to see if it was feasible. It all seems almost ridiculous that we had to even ask that question now, but when we first proposed it, the oncologists were very worried that we might be going to make the tumour grow by exercising patients. There was a problem getting through ethics for similar reasons. There was concerns about the danger of it, everyone told us the patients wouldn't do it. So, here we are a few years later. So it was difficult, and it wasn't as effortless as it might be today to suggest you want to train some patients. We spent some time trying to identify what we thought was the best exercise training program by going to the literature, which was thin for clinical populations. We chose interval training programs not because I think it's better or the ultimate change in fitness is different, but because it acts more quickly. It's important when you prescribe exercise that you describe your exercise programs using the FIT principles, because it means somebody else could perhaps do what you're doing, as opposed to just saying it's an individualized, I tailored it to the patient, I have no idea what intensity it was at. So that sort of exercise program doesn't tend to get such an effective response. So what we did was 3 times a week, we did this little hill program here. So the bottom of the hill, this is heart rate, and the squares are what the patient was doing. Is easy, and the top of the hill is hard. 2 minutes on, 3 minutes off for 40 minutes, as you can see there. And we did everybody with cyclogometry, and we based those work rates on their objectively measured CPEP variables. So we knew exactly what we were doing. And then after 4 weeks, we retested and changed the work rates, because that's the other thing. An exercise program has to be responsive. If you carry on doing the same thing endlessly, the effect changes, reduces. So, what did we find? So this is just an example of one of the cohorts we looked at. This is a randomized control trial looking at locally advanced colorectal cancer. We chose that population because there is a nice window caused by neoadjuvant chemoradiotherapy, and there was a lot of anxiety when we started this as well about delaying surgery for something that nobody knew that worked. And we'd already observed that fitness fell during neoadjuvant chemoradiotherapy. So as you can see, this is the pre-intervention bit. The patient's having chemoradiotherapy and their fitness goes down by about 1 ml per kilo in terms of anaerobic threshold. And their health-related quality of life also goes down during chemo. And that's very reproducible. We've looked at that in upper GI cancer, palliative lung cancer, colorectal cancer, to name a few. And then we started with this exercise training program for the next 9 weeks until they went to surgery. And you can see that their fitness improved by an average of just under 3 ml per kilo, which is both physiologically and clinically significant. And their quality of life improved, and they enjoyed it, and they adhered to the exercise program. So despite having to come to hospital 3 times a week, there was 96% adherence. But what they told us in the PPI feedback from this, and we've got quite a few dedicated patients in these groups, is that we want to be supervised, but we prefer not to have to come to hospital, thank you. So could you arrange for us to feel safe in the community? Because I don't want to go to the gym without anybody, but I prefer not to come up. So on the back of this, and another study where we trained patients all the way through neoadjuvant chemoradiotherapy for esophagectomy, again, so 15 weeks of training 3 times a week in hospital with adherence over 80%. So patients will do this. We decided then to, and we got funding at that point, having shown that it was feasible and safe, no major adverse events and all that training, to go ahead and set up a multi-center, multimodal prehab study looking at the same exercise intervention. So we measured fitness, but this time we put remote bikes in the community in gyms. We trained up some exercise trainers, personal trainers, just gave them a bit of additional training, put an escalation plan in place. And then what we did was send them out to the community in their local gym, and we programmed the bikes from the hospital to deliver the same exercise program that they did locally. And then with anybody we were a bit worried about, we did the first couple of sessions in hospital, so if they were in AF, we were a bit worried they were going to go a bit fast. And actually most of those patients turned out to be fine, so nobody had to do the whole program in hospital. Most of them did a couple of sessions and then transitioned out when there were no issues. So that was all going really well. We'd recruited about 300 patients when COVID hit, and for obvious reasons that became somewhat difficult to do because all the gyms were shut, and all the patients were somewhat distraught about being abandoned halfway through as well. So Sandy, legendary, I have to say that Mike and I were really very busy in ITU at the time, and her and all of our behavioural change team, so all the guys at the front of this paper here, spoke to Macmillan, who'd funded, and our Cancer Alliance, who were funding this study on the right, and came up with a SafeFit study in a matter of weeks and basically transferred people onto that. And that was a virtual multimodal prehab study, not just for patients pre-surgery. That was anybody having active treatment for cancer. And those patients, we were concerned that they might not be keen to do this. We recruited 1,200 patients in 7 months. The website crashed in the first week because we had like 700 referrals, so we had to stop and start again. There was a lot of desire to participate in this. I think COVID made that even more so because people were so isolated. There was a huge amount of emotional distress, that's the other thing to say, amongst cancer patients during COVID. One of the big problems of running this trial became that large numbers of patients appeared to be at risk of self-harm, and then we had to sort of get involved in trying to sort that out, which was very time-consuming. But it's all gone well. Very good adherence again, and this was cancer rehab trainers over the telephone, or if patients could do it by face-to-face video links for exercise training. So the exciting thing about that data is it's about to be published, it's going to go be announced, even though we stopped the Westfit study early at EPOM. All I can say is exciting, so I can't tell you anything else. But anyway, we'll see that then. But in the meantime, this is really fantastic data. And if you haven't got the report about this implementation, you should get so immediately because it's really useful to read. And this is how you're going to get your business case for your prehab training, your prehab service. So this was the Manchester ICS led by John Moore, who you may know is an intensivist anaesthetist up there. And he implemented enhanced recovery and esophagectomy there, and then got funding from the whole ICS to have for the entire of Greater Manchester, a multimodal prehab program, community-based, using exactly the principles I told you, the same sort of exercise that we used. Sandy is we worked very much together on this, and it was implemented across the care system at the beginning of COVID. Equally, they had a bit of a problem because they were doing a similar thing when COVID hit, so they moved virtual. And as part of the funding of this, as part of it was a cancer transformation funding in Manchester, there was an independent evaluation of effectiveness by one of the commissioning teams from the Southwest, so completely independent. This has not been published as an academic paper yet, and I know John's got a lot more data, but this is the data that has come from the commissioning service. So there's 1,500 patients overall, and you can read it about all of this, but I put the colorectal stuff up there because it's the biggest group. And I think really that speaks for itself. So this was, exactly as I've said, exercise training 3 times a week, community supervised, 1.5 days off length of stay, half a day off critical care length of stay, 500 more bed days released. It's very difficult to think of many bad things to say about it. The patient feedback is amazing. The independent evaluation conclusions are taking a value-based healthcare approach. The Fit for Cancer programme provides better patient outcomes and efficient uses of resources. Bed days released per prehab patient cover the costs involved in setting up and delivering this programme for a year, and this is sustainable on a recurrent basis. Ooh, that went funny. I can't remember what the last one was. The evaluation evidence can be utilised by commissioners making decisions about recurrent funding for prehab for cancer services. And I would say I don't see any reason why this should be limited to cancer services. One of the reasons everybody started in cancer is it's easier to get funding. There's nothing specific about cancer per se that would make that relevant to them. And the other thing that is most fantastic about this implementation, evaluation, is that they have demonstrated sustained behaviour change. So they assessed patients at baseline, preoperatively, at discharge from hospital, at completion of a rehab programme, because they did prehab to rehab, which is 12 weeks post-operatively and a year. At 12 weeks, so from baseline to pre-op, fitness improves and physical activity improves. By 12 weeks, gets back to that baseline and the physical activity is maintained. Frailty is reduced, objective statistical change in frailty scores, and at 1 year that was still maintained. So you've got evidence of not only improvement in short-term outcomes, it's what we've been harping on about for ages, there's sustained behaviour change, so all those health benefits of making people exercise for longer. And on top of that, it shrinks your tumour. So there's another good thing. So as I said, the ethics people were very worried about us excising people because they thought that we would increase blood supply to the tumour and that might make the tumour grow faster, which, is completely reasonable. It's only now that seems funny. It didn't back then. So we said we'd do some extra MRIs, and what we demonstrated, and this is the first time that's been demonstrated, and we're doing some mechanism work looking at this now, was that patients who responded to the excise programme had much significantly improved tumour regression on their scans. So this is about the business that I said at the beginning, where being unfit causes cancer. This is probably something to do with that. So it's modifiable, and that's most likely to be, I'm not a basic scientist, so I don't it's not my biggest focus in this area, but the inflammatory pathways are probably one of the targets, and the other are mitochondrial ROS pathways. So the very last thing, I'm only going to go on for about 5 more minutes, you'll be pleased to hear, is about, well, how do we implement it? I've just told you Manchester, and perhaps we should go and ask Manchester because they're clearly doing a good job. But I think there's really enough evidence out there now to be saying that it's going to be difficult, because the last few years NHS England always say show us the evidence, and now there is the evidence, and not only is there evidence it's clinically effective but it's cost effective. I suspect the funding will have to follow, particularly with the politics of the massive waiting list issue at the moment. So there are 2 sets of guidance. There's one Ramani clearly led on in the summer of last year, which was particularly focused on what we should do with people on waiting lists and COVID, but this that Mike led on for the NIHR, and many of us were involved in a couple of years previously, looking at how you should think about structuring prehab services. So I'm just going to go through a couple of characteristics of things you need to think about if you're starting out. And number 1 is that it needs to be needs-based. What do I mean by that? Not everybody needs the same intervention. If you're really fit already and you're already doing loads of exercise, you don't need to go and have supervised exercise program in hospital or at a gym. You probably need some tailored advice about improving aerobic capacity, know what to expect when you come into hospital in terms of early mobilisation, and you can go and sort yourself out, because that sort of person probably has high self-efficacy. On the other end of the scale, someone who's completely inactive may well need some supervision. And so we've divided the way we talk about interventions in prehab into universal, that's the sort of basic human rights that everybody should have, which is information and advice, targeted for those who need a bit more than that, and a very small group at the top who needs specialist intervention. So that would be, and we expect that to be less than 5% in the exercise group, who actually have got aortic stenosis or some such, that actually need to be exercised in hospital with monitoring for the entire of their exercise programme, or they may need to have enteral feeding. The next bit is that there are 3 distinct stages, and it's really important that the screening stage is very early in the pathway. And I would advise digital self-screening is much easier than doing it all face-to-face. And so that there are certain recommendations that that's a good thing to do. And it's different to pre-assessment. This is about screening for modifiable risk factors. It's not about writing a long list of comorbidities. I'll come back to that in a minute. Then you need to assess someone. So if someone on the screening tool is flagged as not low risk, so that's all we do on the screening tool, we get rid of a load of greens and say they're low risk, then the others need some face-to-face, or over the telephone we use a lot for dietetics, assessment to actually see what the issue is and what they need to have done. And then you make an individualised prehab plan and a prescription that may have different interventions at different levels for different issues. We use something called My Medical Record in Southampton. This is something we developed locally, but that's what our screen is. It's DARSA, it's a nutrition risk score, it's a hospital anxiety and depression score, it's a modified Edmonton for frailty, because the patient can't do their own clinical frailty scale, but they can do that. It's Audit C for excessive alcohol. There's some questions about opiate use so that we can refer to chronic pain to reduce, and a stop bang and a smoking score. It's not a long list of comorbidities, doesn't really ask very much about comorbidities, to be honest. The patients fill that, they get a text, they're asked to fill it out. There's variable ability to fill it out. We're now employing people called digital health advisors to help people fill things out. We have a non-digital patient pathway, so some of the high-risk ones have already been asked 46 times to join the system for other outpatient stuff, and they just say, I never want to ever be on a computer ever. And so then you just have to say, well, do you mind if we put you on the computer and we'll do the work, and then we still have the information. This produces a summary that goes into the medical note that's RAG rated like this, so red, amber, green for all of those modalities, and there are some of which are very standardised pathways based on that. Green patient just needs surgery school and app. Red patient might need to be referred to the alcohol referral service. And you can get some standardised letters that allow you to do those reasonably automatically. It's complicated if you get patients early in the pathway because you've then got to follow them up, and whose job is that? And where's the workforce to do that? Because you've just created a massive amount of work. We're slightly struggling with that at the moment, but this is going to hopefully help. And this is about the elective recovery plan saying we need perioperative pathway coordinators, and you do. You know, when I say they need to go and see a dietitian, you need to know who's going to see them afterwards. Does it work? That's just the early data. We started this with elective joints, so that's major arthroplasties. And patients we said we'll screen on the screen. You can see they either got outsourced, where the length of stay was 2.5 days, or they were done at UHS, where we're clearly not so good at it, so it was 3.5 days. Or, as you can see, amber 5.5, and red, you know, even with lots of input, they spend a long time in hospital. Universal interventions. Surgery school, we implemented this in 2018. Imogen, who's our perioperative medicine lead nurse, leads that. It's 2 hours, it was 2 hours of face-to-face education for a patient and their relative. Patients like it. About 60% of them turned up. They changed their behaviour, and patients had been there not randomised, but in an implementation study, had reduced length of stay and complications compared to those that didn't. Again, that went virtual over COVID. And to our surprise, attendance went up, and it appeared to be more effective, not less. So we're going to have a sort of mixed model going forward. Finally, for the reasons I said, you know, advice is all very well, but patients quite often need some support to act on that advice. So this is the myop app that we've co-developed with Myom Health, which is a digital device company. It's actually led by one of the respiratory consultants in Southampton, and they specialise in patient self-management apps. And most of these have been for chronic health conditions. So there's one for heart failure, one for COPD, one for diabetes, one for asthma. And it has a digital kite mark, and it's an NHS England approved digital treatment because it's been shown, the COPD app, to reduce hospital admissions with infective exacerbations in COPD and reduce 1-year mortality. So it's basically engaging the patient to get involved in their management. You can see the domains there. I'm not going to go through those. The important bit is the bit at the bottom, which is that it has screening inbuilt if you haven't got your own tool. It's exactly the same screening tools because we designed what the content was, frankly. So it's on purpose. It's made to match our own screening tool in our electronic patient record. We just didn't want an external one. The important other bit is behavioural change sciences incorporated within it. What do I mean by that? So if you tell a patient to exercise, they're much less likely to do it than if you ask them what exercise they're going to do, and they have to think an answer to that question. Then they have to write it down, they're more likely to do it again. Once they've said what they're going to do, you then have to say, well, what's going to stop you doing it? Can you write them down? And then you have to write down what you're going to do. It sounds really puerile, but it actually works, and you improve compliance by about 10 to 20% each time you do this. And there's lots of data from weight loss, other areas, smoking cessation, that support this. So when you try and ask patients to do stuff before you have your service, these are the sort of techniques you should use. You want to get them to keep a diary. They have to keep a diary of what they've done in the app, and then they get rewards, because we all like a sticker. We are actually still 3. So they have one in Sheffield, where Sheffield Wednesday and Sheffield United, you have to be a supporter of one or the other, and you get points for your club whenever you do some exercise. So that's a sports psychologist there. And then there's this clinician interface that looks rather similar, you might notice, to the other dashboard, but this basically immediately, each line is a patient, and it tells you where they're screening. And within the app, they're asked to rescreen every couple of weeks. So if they're losing weight, it comes up. Very last bit, this looks really complicated. Happy to share it with anybody if you want to. This is our perioperative care pathway now that we're trying to implement, and we're getting funding at the minute. We've got some pump priming funding. So early screening, down here, green, red, amber. Green, go off to an elective hub if they can. Red, come to our shared decision-making clinic. Amber comes up, and red has a proper assessment for prehab needs. Low risk, get the app and surgery school. And signposting to community resources. Targeted interventions, you can see here, it's mainly ONS and see a dietitian. Or for specialist prehab, it is supervised in-hospital exercise. And our main intervention for exercise in the community is using the excise referral scheme, and again, training up the trainers to be able to deal with a new group of patients that they haven't really had before. I don't know if you're aware of this scheme. It started a few years ago. It was woefully underused. A patient can go and join a gym for £20 a month, so massively reduced fees, and then they get to see a personal trainer one-on-one. The issue is that most patients that need to go don't go, and 20 quid's a lot of money for some people. So we're using that. We will be paying that fee, so it will be free. It's a sort of similar system to what we were doing within the gyms. And these people are based in gyms. So they go out there and they have face-to-face, and then they get their exercise program, which we will be sending the prescription to the trainers, and they will deliver it for us in the community. It's really important to get to speak to the organisations. These are all the people that work. We have 2 ICSs. We're on the border of 2 integrated care systems that are delivering exercise in the immediate environment. So spending a bit of time finding what's out there. We've now finally got integrated care system support for system-wide delivery in Wessex, which is really exciting, and that's come in the last few weeks. They're working out the funding model. But with the early screening, a UHS hub, that's a Southampton hub for assessment, and community delivery for the majority of the interventions. I'm going to stop there. I'm going to remember that. I'm just going to leave you with this. Imagine a pill that reduces all-cause mortality, that reduces the risk of cancer, heart disease, stroke, depression, diabetes, frailty and falls, dementia, by about 30% dementia, with minimal adverse effects. Okay? 30% reduction in that improves outcome in cancer, hypertension, heart disease, diabetes and depression, that improves cognitive outcomes in children, that makes patients feel better, function better and sleep better. Surely you would prescribe it. Surely you would want it. Thank you very much.
Denny, thank you so much. I think one of the things that I've missed over the last couple of years is the face-to-face lectures, the talks like this. I think I've forgotten what a brilliant lecturer you are. You are a brilliant lecturer. It was a fantastic talk.
Thank you.
Thank you. I've learned a lot. I'm sure everybody else in the room has as well. We're really grateful to you. Now, having said that,
there's always a sting in the tail.
Fashion, I went to look for something to get you as a gift, a suitably prestigious gift for giving this prestigious lecture. And I went to the UCL shop at about 3 o'clock this afternoon to find it, to only find that the UCL shop is in fact closed.
Oh.
It's another consequence of COVID.
God.
So I was unable to get you what I wanted, but that will come in the post. But in the meantime, there's a little gift from Wallstones as a token of our gratitude. And thank you very much.
Thank you. That's very sweet. Thank you. Thank you.
So the good news is that maybe the live stream will the good news is that UCL doesn't actually know they're in this room, so you're free to drink and booze.